with Dr. Prachi because she has to catch a flight. She'll be presenting a study of central retinal venous occlusion and its correlation with serum vitamin B12 and homocysteine levels. So the duration is 5 minutes. Please timer 5 minutes का कर दीजिए. Okay.
Yes, sir.
Start
Yes,
the
sir.
timer, please. Please start.
Good morning to one and all. I am Dr. Prachi Nalinde, third year junior resident from BJMCN Sassoon Hospital, Pune. I'll be presenting a paper on a study of retinal vein occlusion and its correlation with serum vitamin B12 and serum homocysteine levels in tertiary care hospital. Retinal vein occlusion is a major cause of visual impairment and blindness. There is initial blockage of venous outflow with marked stasis and intraretinal hemorrhages, which is a non-ischemic state. Retinal vein occlusions can further be complicated by capillary non-perfusion, which is an ischemic state. Now, homocysteine is a sulfur-containing non-essential amino acid. Elevated levels of homocysteine leads to thrombosis via mechanisms such as increased tissue factor expression, attenuated anticoagulant processes, enhanced platelet activity, increased thrombin generation, and vascular injury due to endothelial dysfunction. Now the information on the association between homocysteine levels and retinal vein occlusion in Indian population will be useful, and limited information on this issue is available in Indian subcontinent. Therefore, our study reviewed the role of hyperhomocysteinemia in the occurrence of retinal vein occlusion. Aims and objective of my study are to determine serum homocysteine and vitamin B12 level in patients with retinal vein occlusion, to find correlation between levels of serum homocysteine and B12 in patients with retinal vein occlusion and its effect on visual acuity and fundus findings. The materials and methods used, the study setting is a tertiary care health center. Study design is a cross-sectional observational descriptive study. We studied all the patients presenting to ophthalmology OPD for a duration of 18 months on a sample size of 35 consecutive eyes. The inclusion criteria was patients coming to ophthalmology OPD, patients coming with sudden loss of vision in a vitreoretinal OPD, and patients giving history of previous known attacks of retinal vein occlusion. Exclusion criteria was patients of age group less than 20 years and more than 20 years and less than 70 years, patients with conditions like pregnancy, psychiatric illness, chronic alcohol abuse, and anticonvulsant therapy, patients who have been diagnosed with hypertensive retinopathy and diabetic retinopathy, and patients having hazy and opaque media. These are some of the fundus photographs we have taken. Now the observation and results. There was a slight male preponderance, which was observed that 54% of the males were having retinal vein occlusion and 46% of the females. The highest prevalence was found in the age group of 51 to 60 years. Interestingly, 22.9% cases were below 40 years. The average age was noted to be 51.2 plus minus 7.9 years. Now, according to our study, the classification of retinal vein occlusion was that central retinal vein occlusion was involved in 28.6% of the cases, whereas majority of the cases were of branch retinal vein occlusion. Further dividing the branch retinal vein occlusion, 48.6% cases showed retinal vein occlusion and superotemporal arcade, whereas 22.9% cases showed retinal vein occlusion and inferotemporal arcade. The homocysteine and the B12 levels were recorded in the cases of retinal vein occlusion. Homocysteine was found raised in 68.6% cases and normal only in 31.4% cases. Vitamin B12 level was found deficient in 77% cases and normal in 22.9% cases. Now, raised plasma homocysteine is a risk factor for both arterial and venous diseases of retina. Sclerotic thickening of the central retinal artery is a risk factor for occlusion of the adjacent central retinal vein. Plasma homocysteine could also mediate central retinal vein occlusion directly by increasing the risk of venous thrombosis. The increased serum homocysteine levels led to thrombotic event by endothelial damage, platelet aggregation, and thrombus formation, leading to retinal vitamin B12 and B6.
Normally also if you get vitamin B12 or B6 done for any individual, it will be less. So what new have you tried to find out?
The prevalence, it is mostly in young patients like 31 to 40 years of age, and the most common cause of retinal vein occlusion is otherwise hypertension. So for young patients, we can look for this cause of hyperhomocysteine and hypovitamin B12 levels.
That's true that hyperhomocysteinemia should always be ruled out, but this we always do for young patients. Anyway, nice paper, thank you.
Thank you, sir.
Dr. Neeti Agarwal. Dr. Neeti Agarwal is not there? Okay. Dr. Dhruv Jyoti Sarkar. Dr. Dhruv Jyoti Sarkar, not there? Dr. Shravani Sarkar. I would request the next presenters to be ready on the podium once the presenter reaches the conclusion slide so that we don't waste the time. After Dr. Shravani is Dr. Tanvisa. So I would request Dr. Tanvisa to be ready with her presentation once Dr. Shravani reaches the conclusion slide.
Good morning, everyone. The topic of my presentation is determination of prevalence and predictive factors of diabetic retinopathy in a tertiary healthcare center in India. My name is Dr. Shravani Sarkar. There are no financial conflicts of interest to disclose. Introduction: diabetic retinopathy is a sight-threatening complication of diabetes and a major cause of visual impairment. It is the 5th leading cause of blindness globally. Close to 1 million people are blind due to diabetic retinopathy. The burden of diabetes in India is rising exponentially and is expected to reach the numbers of 134 million by 2045. Understanding the prevalence and the associated risk factors is therefore strongly needed to screen patients for diabetic retinopathy and follow them up so that early intervention can be done. Method in this study: we did a prospective cross-sectional study carried out between March 2022 to August 2022. All patients diagnosed with diabetes mellitus seeking treatment in our hospital during the study period were considered eligible. Data was collected from medical records, examination, and using a semi-structured questionnaire. Univariable and multivariable logistic regression analysis were done to identify predictors of diabetic retinopathy using SAS 9.4 software. Coming to results, 181 patients with known history of diabetes were enrolled in the study. There were 112 males and 69 females in the total sample. The mean age was 56.8 plus and minus 12.2 years, ranging between 22 to 87 years. The mean and the median duration of diabetes was 7.14 years and 6.2 years respectively, and ranging between less than 1 year to more than 25 years. There were 35.4% out of, there were 64 patients diagnosed with diabetes retinopathy constituting about 35.4% of the total patients. Out of that, 61% were males and 40% were females. Coming to results section, the age, we divided them into more than 60 years and less than 60 years. More than 60 years, even though it was 1.03% of increased odds, but it was not statistically significant. Male patients were showed a little bit more increased odds, 1.95 times compared to females in the univariable regression analysis. However, in multivariable regression analysis, after adjusting for other variables, it was not statistically significant. Coming to duration of diabetes, those patients with more than 10 years of diabetes had were 3.5 times more likely to develop diabetic retinopathy, which was consistently present even in multivariable regression analysis. Insulin intake, patients were on, those who were on insulin were 4.87 times more likely to develop diabetic retinopathy. That was consistent even with multivariable regression analysis. We also looked at compliance of hypoglycemic medications, and those patients who were not compliant were actually more at risk of developing diabetic retinopathy. Coming to hypertension, patients with history of hypertension were 3.7 times more likely to develop diabetic retinopathy. And patients with systolic blood pressure of greater than 140 mm of mercury were 3.39 times more likely to develop diabetic retinopathy. And patients with hemoglobin HbA1c more than 7% were 2.06 times more likely to develop diabetic retinopathy. Coming to discussion sector, the prevalence in our study was about 35.4%, which was higher than two of the other studies that found a prevalence of diabetic retinopathy around 14 to 15%. One factor could be because it was a hospital-based study, and other two studies were a community-based study. A lot of patients diagnosed with diabetes are aggressively referred to our department for screening of diabetic retinopathy. And also our center provides anti-VEGF injections free of cost. That's another reason for more patients with history of diabetic retinopathy getting referred to our center. These two reasons, I think, could be a reason for high prevalence of diabetic retinopathy in our center. Other than that, systemic blood pressure of more than 140, duration of diabetes, insulin intake, and HbA1c, and poor compliance of hypoglycemic medications and history of hypertension continue to show as independently associated with diabetic retinopathy. And identification of risk factors in diabetic retinopathy is important for education of patients and counseling, so that modifiable risk factors can be controlled, and also to diagnose diabetic retinopathy at early stages. Some of the limitations of our study was sample size consisted of hospital patients, and it was not taken from the community, and relatively smaller sample size. This conclusion, I would say that with rise of diabetes prevalence, diabetic retinopathy is expected to rise. Thank you.
So you should take your podium now. See, that's the whole point. When you talk about prevalence, it cannot be a hospital-based trial. It has to be in the community. So the determination of prevalence and predictive factors in hospital should be the title rather than just prevalence, because whenever you talk about prevalence, you have to go to the community, you have to do a door-to-door study. You cannot do it in the hospital, because in any hospital you will always find greater number of complications, because those patients who have problems will come to the hospital. Those diabetics who don't have a problem, they will not come to the hospital.
Yes, sir.
So then your study, that is why it's skewed towards higher number of
prevalence.
patients with diabetic retinopathy. So you have to go to the population and do these studies.
Our next plan is to
Where is your hospital?
Silchar Medical College. It's in Assam.
Okay, so unfortunately we have studies from the south, but we have no studies from North India,
Yes, sir.
from
That's right.
Eastern India, or even Western India. We don't have that data. So I would suggest that if possible, you should try and do a study in Assam
Yes, sir.
to know the real prevalence
Yes, sir. We
and
intend
add
to
to
do.
the data that is
Yeah.
already there.
Yes, sir.
Since you have an interest, probably you can do it.
Sure, sir.
Thank you.
Okay, thank you, sir.
So the next paper is Association of Midlife Anxiety with Diabetic Retinopathy in Spite of Good Vision, and the presenting author is Dr. Tanvisha Chakraborty.
Good morning to all. This study is an association of... This study is an association of midlife anxiety with diabetic retinopathy in spite of good vision, and I have no financial interest. So what we know is oxidative stress and chronic inflammation are both involved in the pathophysiology of diabetic retinopathy as well as anxiety. DR, due to its chronicity, also leads to physical and psychological stress, which causes anxiety. And most of these studies are centered around the elderly patients and those with poor vision. Regarding this context, we found two important studies. One, a Chinese study which showed no association between diabetic retinopathy and anxiety, and another Australian study showed a higher prevalence of anxiety and established various risk factors for anxiety in diabetic retinopathy. But the question is whether anxiety is related to diabetic retinopathy in middle-aged type 2 diabetes mellitus patients, even with good vision. The general objective of our study was to compare the association of anxiety measured by the Hamilton Anxiety Rating Scale in middle-aged type 2 diabetes mellitus patients with and without diabetic retinopathy. So this was an institution-based cross-sectional case control study carried out at the retina clinic of our department and Department of Biochemistry at Calcutta National Medical College for 1.5 years. Controls were the middle-aged type 2 diabetes mellitus patients without diabetic retinopathy and cases with diabetic retinopathy. The sample size calculated as 56 cases and 56 controls as per previous data. The Hamilton Anxiety Rating Scale is a 14-item clinician-rated anxiety rating scale used to assess the severity of symptoms of anxiety, and it was one of the first and most widely used scales. The FBS-PPBS was estimated by a semi-automatic analyzer, and the HbA1c cortisol estimated by enzymatic method, and CRP was estimated by ELISA method. We included 45 to 65-year-old patients of either gender with duration of diabetes 5 to 15 years and a BCVA of 618 or better. And we excluded patients with known history of anxiety, psychiatric disorders, hypothyroid, with other chronic diseases or significant media opacities. After informed consent, we recruited patients into the study and did history and physical examination, followed by the biochemical assessment, and then anxiety scores were assessed by the HAM-A scale. All of this was completed within 7 days of presentation and the data recorded in a Microsoft Excel sheet. So we saw that the age of the patients were matched, and we saw that the glycosylated hemoglobin was significantly higher in cases as compared to controls. Within cases, advanced DR cases were found to have higher glycosylated hemoglobin. The serum cortisol values taken at 4 p.m. were found to be higher in cases as compared to control, and this was statistically significant. The CRP levels were also found to be higher in cases, and when within cases when compared between the grades of diabetic retinopathy, advanced DR showed higher CRP values. The HAM-A scores were significantly higher in cases as compared to control, but when compared between the grades of retinopathy, no significant association could be established. We also compared different items of the Hamilton Anxiety Rating Scale, and even though several of the factors showed higher values in cases, only anxious mood and fears were found to be higher in advanced DR compared to the other grades. So we know that DR and anxiety are found to be related in elderly population as per previous literature, but in our study, in the middle-aged group as well, we saw that there were higher serum cortisol, serum CRP levels in the cases compared to the controls, and also higher anxiety scores as per the Hamilton Anxiety Rating Scale were observed in cases. The limitations of our study was a cross-sectional design and small sample size. We could not establish a causal relationship. The HAM-A scale itself cannot differentiate between anxiolytic and angiodepressant effects and somatic anxiety from somatic side effects. This study was also conducted in a tertiary care hospital, so it is limited to a specific population, hence the results cannot be extrapolated to the general population, and anxiety coexists with depression, so the results could have been interfered due to depression. So we can conclude that anxiety and diabetic retinopathy are related in middle-aged type 2 diabetes mellitus patients with good vision, and a holistic approach in management will ensure better outcome for diabetic retinopathy. These are my references. Thank you.
Dr. Millie, can you come in?
Nice study, very well presented, and so this is a known fact that nowadays diabetes is not because of increase in intake of sugar, it's more of related to the lifestyle and the anxiety. So I congratulate you on bringing this and emphasizing it again. Thank you.
Thank you, sir.
Next speaker is Dr. Millie Mandal. She'll be speaking on association of midlife hepatic steatosis with diabetic retinopathy, a cross-sectional study.
A very good morning. This is Dr. Millie Mandal, and my topic of presentation today is association of midlife hepatic steatosis with diabetic retinopathy, a cross-sectional study. So according to
Restart the timer. Restart. Go to your first slide, please.
okay. Sir.
Okay.
I think it's A very good morning. This is Dr. Millie Mandal, and my topic of presentation today is association of midlife hepatic steatosis with diabetic retinopathy, a cross-sectional study. According to World Health Organization, the disease burden of diabetes is about 422 billion, and there are about 2 million deaths due to diabetes and its complications. Talking about diabetes, it leads to a state of chronic inflammation and increased oxidative stress. A similar kind of disease entity, which is non-alcoholic fatty liver disease, also shows this pathogenesis. The most prevalent age group of diabetes is the middle age group, which ranges from about 45 to 64 years. So what are we trying to assess here? We are trying to assess the association of diabetic retinopathy, which is the most common complication of diabetes, with hepatic steatosis in the middle-aged population, so that early detection can prevent advanced hepatic damage. The aims and objectives. We are trying to measure and compare hepatic steatosis by hepatic steatosis index and liver elastography in type 2 diabetes mellitus patients without retinopathy and T2DM patients with retinopathy. So we'll be assessing and comparing HSI and elastography between the two groups, and also finding the relationship between severity of diabetic retinopathy. So this was an observational cross-sectional study conducted over a period of 1 year with a sample size of 57, where we recruited patients, consecutive patients in the middle age group, having diabetes from 5 to 15 years. We went on with ocular examination, lab investigation, and radiological investigation, and data compilation and analysis was done. We followed a strict exclusion criteria. Coming to the ocular examination, it was done and graded by a single clinician. Lab investigation, we performed within 7 days of inclusion of patient in the study. And radiological investigation, we went in with ultrasonography and hepatic elastography. This was also done by a single radiologist who was blinded. So we studied 3 parameters. Number 1, hepatic steatosis index, which is a non-invasive parameter based on ALT-AST ratio and BMI to quantify liver steatosis. Number 2, USG liver. And number 3, shear wave elastography, where we went on with assessing the LSM cutoff values measured in kilopascals and used the Metaway score. So what is hepatic elastography? Hepatic elastography is a shear wave elastography. It is a radiological method of assessing liver steatosis, and it measures tissue stiffness. Coming to the result, this is a table which is showing the baseline parameters of cases versus controls, where we can see that the age came out to be significant, and later on we went with the linear regression, and the difference persisted even after regression. This is the chart which is showing the hepatic steatosis index with a p-value of 0.012. This is the bar which is showing the hepatic elastography with a p-value of less than 0.001. So what can we conclude from the study? The hepatic steatosis index was significant in the 2 groups. The severity of diabetic retinopathy in HSI was not significant. But hepatic elastography was significant in both the groups despite a non-significant hepatic ultrasonography. Though the study had a few limitations, being a single-centric study, there was no randomization. It had hospital bias and confounding factors for which we went on with linear regression. We can conclude that our study identified diabetic retinopathy as a risk group for hepatic steatosis in middle age. Though we need to have longitudinal study to know the temporal association, hepatic elastography detected midlife hepatic steatosis, which was not otherwise detected by ultrasonography. Hence, we recommend screening patients of diabetic retinopathy in the middle-aged population for hepatic steatosis so that we can detect it and prevent advanced hepatic damage. With this, I would like to conclude with the thought that an ounce of prevention is worth a pound of cure by Ben Franklin. These are my references. Thank you.
So, did you have a control of patients without diabetes and whom you could check for hepatic steatosis?
So we checked and assessed steatosis in both the groups.
Was there I couldn't see any control. Was there a control group
Yes, sir.
who did not have diabetic retinopathy?
Who did not have diabetic retinopathy? Yes, sir. It was there in the methodology. Mild, moderate, severe.
No, no. Go to your slide with the bar charts.
Yes, sir.
This
Yes.
this control for these patients. These are what patients? Normal
Without
patients?
retinopathy, sir.
Diabetic patients
Without
retinopathy.
retinopathy.
Okay. You do not have any patients, normal patients without diabetes
No,
to
sir.
compare with diabetic patients? That's
No,
what
sir.
I'm asking.
No, sir. We compared diabetic patients, one group with retinopathy, another group without retinopathy. So here we are basically assessing the microvascular complication, whether it has got something to do with the microangiopathy which is induced in the liver due to the common pathway that they're sharing.
Any, did you try and compare with the renal status also of the patients?
Sorry, sir, I didn't know.
The renal status.
So we did not, yes, sir, we went on with the assessment of the kidney function test also. That was the exclusion criteria. We excluded patient with diabetic nephropathy. We assessed the urine ACR levels also, and we excluded them. It is
But
there in
then-
the exclusion criteria.
But then if you're saying microangiopathy, then microangiopathy in the eye, microangiopathy in the kidney, and microangiopathy in the liver should all be together.
No, so we are not saying that. We are saying it is not getting manifested. We are detecting early steatosis. That means hepatic steatosis is being detected early, which is not detected with ultrasonography. So if we send the patient of diabetes with retinopathy for ultrasonography, that patient will show a normal ultrasonographic figure when we are comparing the liver. But when we are detecting them with hepatic elastography, then that patient, the difference is coming to be significant, which in turn is detecting early steatosis, early steatotic changes.
What are the other causes of non-alcoholic steatohepatosis?
Sir, other causes can be the presence of or intake of diet is one of the factors. Second, sir, it could be due to the this steatogenic medications like amiodarone, methotrexate, valproate.
None of your patients were under these medications.
No, sir, we excluded the patients of, it was there in the exclusion criteria.
Okay, thank you. Dr. Subhojit, are you here?
Thank you,
Please
sir.
come. So Dr. Subhojit will present association of serum-free iron with diabetic retinopathy in middle-aged type 2 diabetes mellitus.
May I request Dr. Muazzam Pervez? Dr. Muazzam Pervez is there? Dr. Sasmita Sahu? Yeah, just be ready once he comes to the conclusion slide.
Good afternoon, respected judges. The topic for my presentation today is association of serum-free iron with diabetic retinopathy in middle-aged type 2 diabetes mellitus. I have no financial interest. Oxidative stress and chronic low-grade inflammation has been observed in the pathophysiology of diabetic retinopathy. Iron, though an essential micronutrient for retinal functions, however, non-transferrin bound ferrous iron generates reactive oxygen species and free radicals have been implicated in microvascular complications of diabetic retinopathy. Oxidative stress induced increased ferritin synthesis also causes derangements in insulin resistance. Now, studies focusing on middle-aged population is lacking all over the world. Many risk factors associated with diabetic retinopathy remain yet unaddressed, and if an association of iron profile with diabetic retinopathy is found, then modifying disturbances of iron homeostasis at an early stage can halt the progression of diabetic retinopathy. It could also lead to the development of new, affordable, and long-lasting treatment options for the future. We aim to assess in our study the levels of serum free iron and ferritin in type 2 diabetes mellitus patients with and without diabetic retinopathy, and to compare the levels of serum free iron between different grades of diabetic retinopathy. This was an institutional-based, non-randomized, observational case control study conducted over 1.5 years among consecutive middle-aged patients with type 2 diabetes mellitus attending our retina clinic. 60 cases and 60 age and sex match controls were studied. Patients with diabetic retinopathy were classified according to modified ETDRS classification by a single observer. Those with severe non-proliferative diabetic retinopathy and proliferative diabetic retinopathy were clubbed into advanced diabetic retinopathy group for ease in calculation. Now, patients with chronic liver disease, diabetic nephropathy, those having blood transfusions over the last 4 months, hemoglobinopathies, iron poisoning or toxicity, drugs known to alter serum iron levels, urinary albumin-creatinine ratio more than 300, glycosylated hemoglobin more than 9%, and heavy smokers were excluded from our study. Serum-free iron and ferritin was assessed using spectrophotometric assay by bathophenanthrolin method and chemiluminescent immunoassay respectively. All samples were assessed within 7 days of patient recruitment in our study. Statistical tests were performed, and a p-value of less than 0.05 was considered as statistically significant. There were statistically significant differences observed in baseline characteristics among cases and controls in our study, and the following figure shows the distribution of severity of diabetic retinopathy among the cases group. Now, higher levels of mean serum-free iron was observed in patients with diabetic retinopathy in our study with statistical significance. However, there was no statistically significant differences observed among different grades of diabetic retinopathy, which remained non-significant when the results were stratified on the basis of gender of the study subjects. Now, higher levels of mean serum-free iron was observed in the late midlife age group of 55 to 64 years in our study. Glycosylated hemoglobin was positively correlated with serum-free iron in our study. The following tables show the results we obtained in our study. Now, we also aim to establish a cutoff, levels above which would threaten risk of progression of diabetic retinopathy, and higher number of advanced diabetic retinopathy cases was observed in the third quartile of serum-free iron. Relationship of diabetic retinopathy was also compared with normal range of serum-free iron, which was also stratified on the basis of distribution on the basis of gender and age groups of the study subjects, and significant results were obtained. Now, as we all know, that serum ferritin is a widely recognized index of body iron stores. It was seen to positively correlate with duration of hyperglycemia and was also seen to negatively correlate with alanine aminotransferase levels in our study. It is an independent marker of non-alcoholic fatty liver disease progression and is also associated with lipid peroxidation seen in diabetic retinopathy. Now coming to the discussion part, results in our study broadly showed that potential mechanisms interplay between iron homeostasis and diabetic retinopathy progression. Also, late midlife is associated with higher levels of mean serum-free iron, which is attributed to aging and hyperglycemia-mediated damage to the ferritin structure, releasing iron in its free state. Our study had certain limitations. Serum ferritin is an acute phase reactant, and though the regression with CRP gave significant results, serum transferrin would have been a more reliable marker. There is poor representation of general population due to small sample size, and many studies show a diurnal variation of body iron stores. However, in our study, only spot samples were assessed. In conclusion, we can say that there is an association of iron profile with diabetic retinopathy in middle-aged type 2 diabetes mellitus and a need to assess iron profiles in the future. However, a prospective study can establish a cause-effect relationship. The following are my references. Thank you.
that anemia causes, like, it increases the risk of diabetic retinopathy.
Yes, sir.
So what have you tried to find out through this paper?
Sir, serum free iron has many mechanisms. It can cause oxidative stress, and which is the most important. Other mechanisms are also involved. We aim to find out through a spectrophotometric assay that how much serum of the ferrous iron, how can it lead to the pathophysiology of oxidative stress mechanisms, which is the major mechanism leading to microvascular complications of diabetic retinopathy. So that screening for iron profiles in the future can lead to developing a screening and treatment options for the futures.
So, like, if the patient is having deficient iron levels, so what is the treatment? It's whether you assess hemoglobin or different factors, what are you going to do through it?
So we have to assess the hemoglobin also, and apart from anemia, there are other factors which cause change in iron homeostasis. We have to be wary about that part also.
If the patient is having anemia, you will give iron supplement.
Yes, that.
So that iron supplement should cause the patient to reverse his anemia, or is going to cause more damage.
Sir, we will start treatment and then monitor.
And then?
Monitor for the.
See, our aim should be clear. The aim of the study should be clear. We should try to find something new. We should not, there's no doubt to paper on the levels of iron being liquid with whatever transferring or 95 max is already. So what have you tried to find new?
So anemia was an exclusion criteria, and other hemoglobinopathies which can alter the iron profile was an exclusion criteria in our study. So apart from the factors which are known to cause changes in iron profile, there are many other factors and ferrous iron is a completely different entity in itself.
What is the source of the ferrous iron?
So ferrous iron is from ferritin, it bounds to ferritin.
No. What is the source of ferrous iron coming into the body? It has to come through the diet.
Yes.
So what is the source? From where is the ferrous iron coming?
So from dietary sources it is coming, and then
yes,
it is.
for what is this? That we know it's in the diet. In what utensil person is making, will that make a difference? From where is the ferrous iron coming in the diet?
Sir, it is an important part of the diet only itself.
Okay, fine. Thank you.
So now we have Dr. Sasmita Sahu. She will be speaking on 2-year visual outcomes of anti-VEGF treatment of diabetic macular edema in a tertiary care hospital.
Good afternoon all. My paper is on 2-year visual outcomes of anti-VEGF treatment of diabetic macular edema in a tertiary care hospital. Diabetic macular edema represents a prevalent and disabling eye condition. Its prevalence in diabetes is 5% in 5 years and 15% in 15 years. OCT, being a non-invasive, non-contact imaging modality, plays a crucial role in the early diagnosis of macular edema and for deciding the treatment. Vascular endothelial growth factor has a crucial role in pathogenesis of diabetic macular edema, and now it is preferred as a first-line treatment for the same. My aim of the study is to study the 2-year visual outcomes of anti-VEGF treatment of DME in a tertiary care hospital. Coming to materials and methods, it's a retrospective study that took place in Rio SCB MCH Cuttack for a period of August 2020 to 2022. And the medical samples were taken from the medical records of 200 diabetic macular edema patients. After considering the inclusion and exclusion criteria, 120 patients were included. Those patients were having incomplete ophthalmological data, significant vitreomacular traction, macular scar, or any previous laser were excluded from the study. The method of evaluation includes the complete ophthalmological examination at the first visit, along with OCT and complete blood investigation. The participants received 3 consecutive injections of ranibizumab 0.5 milligram at the first 3 visits, that is from 0, 1, and 2 months. This is the image of a patient of diabetic macular edema receiving intravitreal anti-VEGFs in our setup. Coming to the results, in our study, we found the patient aged between 51 to 60 years has a more prevalence of diabetic retinopathy, that is 55%. There is a female preponderance, and incidence of diabetic macular edema with duration of less than 5 years was 28%, in 5 to 10 years was 52%, and in 10 to 20 years was 20%. 22% of patients were having mild NPDR, 45% were having moderate NPDR, and 33% were having severe NPDR and early PDR. In our study, we found the spongiform pattern of CSME was most common, followed by cystoid macular edema, and then CME with serous detachment and posterior hilar traction. At the time of presentation, 12 patients were having best corrected visual acuity of 6 by 6 to 6.9, 36 were having 6 by 12 to 6.18, and 72 number of patients were having best corrected visual acuity of less than 6 by 24. After receiving intravitreal injection, BCVA gain at the end of 12 months, the VA gain of more than 2 lines were 25%, and 34.9% were having VA gain of more than 3 lines. At the end of 24 months, 14% of patients were having a VA gain of more than 2 lines, and 19.3% of patients were having more than 3 lines of visual acuity gain. At the time of presentation, CMT measured by OCT, there were 29% of patients were having in the range of 270 to 351 micron, and 50% were in the range of 351 to 500 micron, and 21% were having in more than 500 micron central macular thickness. After receiving intravitreal injection at the end of 2 years, there was seen a significant reduction of central macular thickness. At last, we conclude that BCVA gain of more than 2 lines and 3 lines at the end of 1 year and 2 years was statistically significant. There was significant improvements in macular edema were noted on OCT. Eon et al., Kwang Dong et al., and Datta et al. Was some studies that found the similar results, which was in accordance to our studies. At last, we conclude that our analysis shows the effectiveness of anti-VEGF treatment in diabetic macular edema patient, and more intensive treatment should be implemented in the management of patient in order to achieve a better visual outcomes. These are my references. Thank you.
So, how many intravitreal injections you have given over a period of 24 months?
So actually, first we give for 3 doses, that is 0, 1, and 2. Then Puronata, according to the macular thickness, we are inject at an interval and an average 5 injections.
Over 24 months?
No. According to the central macular thickness, patient to patient it varies.
Okay, so it varies. So where is that data?
Sir?
Where is that data? You have to tell us the number of injections you are giving.
Okay, so that is not.
You are showing association of anti-VEGFs with visual acuity. So, number of injections over 12 months, first 12 months, number of injections over the next 12 months, that will add to the value of the study.
Okay, sir.
If you're not giving us the number of injections, we don't know, is it monthly? Is it on treat and extend basis, PRN, whatever you're doing?
Sir.
So that did not come. Which injection were you giving?
Ranibizumab, 0.5 milligram.
Which one? You have shown the photograph of Accentrix.
Lucentis, sir.
You're giving Accentrix for all your patients?
Yes, sir.
This is a clinic which the patient has to pay, or hospital bears the cost?
So it's a hospital base. Government hospital setup, sir.
It's a government hospital, and the government hospital pays for the Accentrix.
Sir.
Any other questions? Himadri, any other questions?
You said on an average you gave 5 injections.
Sir.
So over 2 years, only 5 injections.
Yeah, so some patients are.
Did you have diabetic macular edema in both eyes of any patient?
Yes, sir. In some patients, both eye, but the worst affected eye is included in our studies.
Okay, thank you.
Thank you, sir.
So the next presenter is Dr. Jigyasa, is she here? Jigyasa Srivastava? Not here. Okay, just a word I would like to ask all the presenters. See, when you are presenting anything in an All India conference, you have to declare your financial interest, which you haven't, and you have to tell us whether you have taken ethics committee approval, which was not there in any of your slides. That these two things are mandatory for any presentation at an All India level. You have to tell us whether you've taken ethics committee approval from your hospital, and you have to declare your financial interest. It may not be there, you may not have any financial interest, but you have to declare it. The first slide is your name, the second slide should have disclaimer, no financial interest, and ethics committee approval taken. You have to have these two things which are mandatory at an All India level. Since this was the first midterm conference, many things have been allowed. Your papers have been allowed without many, corrections or whatever. But when you present for the All India conference, annual conference, you will have to have these two things. So remember to have these two things always in your presentation.
If you don't have these two things, then you get negative marks. Like your paper will never go to the finals. Do we have Dr. Aswarya Mohanty? So Dr. Aswarya will be presenting on OCT. Can it be a predictor of eclampsia? Yes, please.
Good morning everyone. Myself Aishwarya Mohanty is going to present on OCT. Can it be a predictor of eclampsia? There is no financial interest. Preeclampsia with a prevalence of 3 to 8% of prevalence has become the leading cause of maternal mortality, especially in developing countries. It is a multi-system disorder affecting eyes and visual system. Emphasizing the pathogenesis, reduced blood flow to placenta due to fibrospiral arterioles results in placental hypoxia ischemia, which leads to fetal growth restriction and in severe cases fetal death. There is also release of pro-inflammatory proteins into the maternal circulation, leading to endothelial dysfunction and systemic vasoconstriction, eventually resulting in maternal hypertension. And due to local vasospasm, there is major organ damage in kidney, retina, liver and brain. Visual symptoms are usually most common in third trimester, including blurring of vision, photopsia, scotoma, diplopia. Ocular findings include conjunctival vascular anomalies, hypertensive retinopathy, exudative RD, vitreous and preretinal hemorrhages, ischemic optic neuropathy, and hypertensive choroidopathy. There are very few clinical studies on preeclampsia's retinal changes. Objective and quantitative retinal imaging methods were lacking. So with the advancement of OCT, an attempt has been made to study RNFL changes in pregnant women with gestational hypertension in the age group of 18 to 45 years and establish the potential contribution of OCT as an eclampsia predictor. It was an observational prospective study including all the patients diagnosed with gestational hypertension by the Department of Obstetrics. It excluded pre-existing diabetes, hypertension, renal disease or any other retinopathy. An informed consent was taken from 35 patients after satisfying inclusion-exclusion criteria. Details pertaining to family history of hypertension, age, parity, gravida, and blood pressure were documented. Baseline data was collected. A comprehensive ophthalmological examination was done including external examination, BCVA, slit lamp, IOP, detailed fundus evaluation, and peripapillary RNFL thickness was measured at first visit at 28 weeks and 2 months postpartum by HD-OCT. The severity of PIH was classified into preeclampsia and eclampsia according to ACOG guidelines. Now coming to results and discussion, maximum of my study population belonged to the age group of 30 to 40 years, with mean age being 32.48. The youngest patient in my study was of 20 years of old. There were 23 primigravida and 12 multigravida patients, and maximum of them belonged beyond the age group of 30 years. According to ACOG guidelines, there were 28 mild and 7 severe preeclampsia patients. On comparison of RNFL thickness from first visit to 28 weeks of gestation, in the mild preeclampsia group, there were 7 patients who had thicker RNFL thickness, 15 had no change and 6 of them had mild thinning. Likewise, in the severe preeclampsia group, 3 had no change and 4 had thicker RNFL layer thickness, out of which 2 patients ended with new onset convulsions who were terminated emergently. The mean RNFL layer thickness in the severe preeclampsia group increased from 96 micron at first visit to 10 micron at 28 weeks, and which decreased significantly to 98 micron postpartum. This was found consistent by a study done by Arab M et al. In the mild preeclampsia group, there was no significant change. Highlighting the fundus changes, 13 patients had no hypertensive changes, 7 had grade 1, 6 had grade 2, 5 had grade 3, and 3 of them had grade 4 hypertensive changes. One of our study population was diagnosed with exudative RT on post-op day 2 of LSCS. Similarly, Reddy reported 53.4% of preeclampsia and 71.2% of eclampsia patients had retinal changes. These vascular changes in the retina that typically correlates with the severity of systemic hypertension. Therefore, observing the retinal changes can help in assessing the disease severity. Therefore, to conclude, I would like to say preeclampsia was more prevalent among the elderly primigravida in this study. Severe preeclampsia patient had thicker RNFL layer thickness during the pregnancy, which decreased significantly postpartum. At the same time, there was no change in mild preeclampsia group. And OCT with ocular fundus changes may be helpful in predicting the maternal risk, diagnosing the patient early, and it can help guide the obstetrician in early and prompt management. Therefore, fundoscopy is highly recommended in all these patients, especially in elderly primigravida during the antenatal visits, and there should be frequent follow-up. Secondly, SD-OCT can be used as a routine screening tool in all these patients before any vision-threatening complications can occur. Thank you.
How frequently would you recommend the screening to be done?
So, firstly, these all are pregnant women. After third trimester, it is very difficult for them to come and go for check for the OCT. But if the patient is willing, we should go for frequent changes so that we can predict the eclampsia. No, I'll do this monthly, not weekly.
Starting from which trimester?
Sorry, sir. Starting from third trimester. Actually, the visual changes that start from the third trimester, so we can. If it is very frequent, then it is good, but it is not possible for pregnant patients.
I think this kind of study can only be done in a multi-speciality hospital
Yes,
where
sir.
you have
Yes, sir.
opthal department and a gynec department together.
Yes,
in a
sir.
solo practice, it's going to be very difficult, and for the patients to understand the need for an eye examination, a pregnant lady, even the gynecologist would hardly find the need to send a patient for
Yes, sir.
an
So,
OCT.
but ours was a multi-speciality hospital, and consent was taken for every patient.
Yeah,
And
that's why it's possible in a multi-speciality
sir.
setup. Otherwise, it's difficult to do it.
Yes, sir.
You know, the problem which we are struggling with in peripheral cities is that even after the vision loss, the gynecologists are not ready to terminate the pregnancy. So we are still struggling with that change. So this is definitely a long way to go.
Yes, sir. Thank you.
So with that, we come to the end of this session. So you have a session? Yes. Okay. Please come. I request all the participants, the speakers, to kindly come for a group photograph.